All right, awesome. Good morning, everyone. Welcome to our second session of virtual shadowing. As today's guest, we have Dr. T, who's the current chief resident at Kaiser San Jose's family residency, and she will be presenting us a few patient cases, followed by a Q&A. So just to start off with some quick intros, my name is Kalena Sarika. I am one of FAC's social chairs, and my pronouns are she, her, hers.
Hi everyone, my name is Jed, pronouns he, him, his. I'm a fourth year NPB major and this year is FAC president.
Hi everyone, I am Raf, pronouns he, him, his. I'm this year's FAC representative and I am a second year global disease biology major.
Hi everyone, my name is Michaela Lamb. I am this year's FACTern and I am a second year human development major.
Cool. I'm Dr. T. Good morning, everyone. Pronouns she, hers.
All right, and with that, you can get started whenever you're ready.
Okay, great. I'm very excited to be here. I have not tested out the share screen, so we'll go ahead and share this. And I'm hoping that this is kind of interactive, casual, interrupt me. I'm excited. I think a lot of learning comes from the question and answer just because it's, guided by you guys. But hopefully this is a good kind of virtual shadowing experience. So we'll go ahead and, do you guys see my PowerPoint? I see a thumbs up. Okay, awesome. All right. So this picture is in Boracay, which I love traveling. I just wanted to start there. And then a little bit more about me. Again, I'm a proud MD raised by an RN. My parents are Filipino. I grew up in San Jose, California. There's a photo here. My claim to fame is that I'm related to Callie there, if you can spot her. I studied public health at UC Berkeley and I minored in global poverty and practice, where I was able to go to the Philippines. That top right picture there in the corner is me in one of the kind of urban areas with some of the kids. So I did my capstone there, advocating for reproductive health and kind of the Reproductive Health Bill. I took 2 years off. I started coaching volleyball again. I grew up playing volleyball and basketball, big Warriors fan. We had a tough week, but there's me and my husband and Mr. FAB, Bay Area legend there. And then I went to med school at Virginia Commonwealth University. That picture down below is me in Palawan, and that was one of the trips I took after taking boards. So I was still able to travel and kind of, have fun through medical school. And then I went through the match, which you can ask about if you guys don't know about. And I am currently finishing up family medicine residency at Kaiser San Jose. So again, kind of goals and objectives. I knew this was a little flexible. And so I kind of hope that it's a virtual clinical shadowing experience for you guys. I know with COVID, that's been really tough. And also it's because I love what I do. I'm kind of telling you more about family medicine and then going beyond that and talking about kind of the art of medicine. Why are you guys doing extracurriculars? What is there to look forward to and kind of big picture stuff. So we'll start with, this is kind of an example of maybe half of my morning. Usually I'll see about 9 to 10 patients in a half morning. So I figured I would just kind of show the breadth of family medicine and what I'm able to do in the time that we were given. So we'll start with a 21-year-old male who presents with ear pain. I don't know, and again, definitely feel free to unmute yourselves. Like, I don't know what your guys' kind of experience is, but let's pretend you're a medical student now, right? Or you are shadowing and we say, go ahead and go in there first and go ahead and talk to the patient. All you know is that he's having some ear pain. What kind of things do you want to know? Or how do you know what questions to ask?
I feel like you could ask when the pain started and if it's more like an internal or external type of pain.
Mm-hmm. And there's so many things to be curious about, right? And so one quick kind of thing that I learned in medical school is this little mnemonic. So I remember it as little quick questions to save my ass. I don't know if I'm allowed to say I know we're recorded, but and so it kind of goes through sort of a systematic way of at least getting the foundation of a history, right? So this is where you're gathering history. Like you said, Callie, it's location, quality, what does it feel like, quantity. Sometimes, you know, you always say like on a scale from 0 to 10. I don't actually normally do that, but I just kind of ask them how it affects their life. You know, like how bad is it? Like, you know, if it's 1 out of 10 and they've waited a month to come in, why today, or something like that. Timing is kind of, you know, how long it's been going on. Setting is more so, did anything, you know, what happened when were you doing anything when it started? Was there a trauma? Like, what were you doing when you first noticed it? M is for modifying factors. So what makes it better? What makes it worse? What have you tried? And then A is associated symptoms. So hopefully you guys remember that. Little quick questions to save my bottom. All right, so kind of going off that, he tells you that it's both ears, and it's kind of a 3 out of 10. So mild discomfort, constant dull with occasional sharp pains. It started 2 weeks ago, and initially kind of the setting of it was that he was having a lot of ringing in his ears. It's worse in the morning, this kind of discomfort that he's having, and also with eating or chewing gum. He says nothing makes it better. He's been trying Q-tips. He's been seeing if there's anything in there. And he does have some associated jaw pain and a little bit of a headache, kind of both sides. So after you get the history, kind of the next step would be looking at your differential diagnosis. So what kind of things do you guys think about with ear pain? Or do you have any follow-up questions?
I feel like I usually associate ear pain with like an infection, maybe.
Mm-hmm. Yeah, so asking like, oh, do you have a fever, right? Anything coming out of your ear? Anything else it could be? It's a very common complaint.
I think I associate a lot of people I know who have ear pain, they tend to get like migraines or headaches. So I would ask that too, like, have you been experiencing migraines?
Yeah, because it's all kind of in this area, right? Awesome. And he's using Q-tips a lot. I always ask about that. Is there any trauma, you know? All right. So there's a lot of different things. Cerumen impaction is just earwax, a fancy word for saying that. Sometimes allergies, when the sinuses are, you know, congested, you can have eustachian tube dysfunction. It's all sort of related. So sometimes I'll also ask you, do you tend to have allergies? Do you use a nose spray? Trauma, Q-tips, right? And then obviously bigger things to worry about. Is there like a mass? Is he off balance? Is he kind of like losing other kind of alarm symptoms? All right, so on physical exam, in general, he's in no acute distress, right? And I think that you can really get a lot from just walking into the exam room, seeing if someone's like, you know, curled up in pain or just looks sick. And that's one thing that we definitely recognize in medicine. That's a big kind of first step. Like, is this person super sick? Do I need to do something? But he's pretty comfortable, healthy, young 21-year-old. On his kind of head, ears, eyes, neck, throat exam, normocephalic atraumatic just means that it's like he just has a normal round head. I don't know if you've seen that, if you guys are scribes or anything. Can anyone take a guess at maybe what some of the acronyms are if you have seen them?
I think TMJ is like tendomuscular junction.
Temporomandibular junction. That's good. EOMI, extraocular movements intact. Pupils equal, round, and reactive to light and accommodation. It's crazy. I just kind of put this here to like show you all the jargon there is. Bilateral tympanic membrane. They're kind of pearly white. Normal landmarks, you'll kind of see it. So is normal essentially, but he did have some tenderness in kind of that jaw area. And then usually I'll ask him, you know, go ahead and open your jaw and you may hear some clicking. So does that change our differential or add anything to it?
I think when there's clicking, doesn't that have something to do more with like the tendons?
Yeah, so you could just have like a disorder here, right? he said that there's a ringing in the ears, which is actually pretty common with TMJ. And so I'll ask that question a lot. Eating, chewing gum, can it aggravate it? And sometimes it's worse in the morning and can associate with headaches because there's so much tension in that area in the morning, because people actually tend to grind their teeth at night. And so if you are grinding your teeth, you kind of wake up with these headaches. So what do we do next? I like this meme because I think it's funny when people are just like, oh, it hurts when I like chew gum. And it's like, no, just stop doing that, or, you know, stop using that. So it's really important. I think one of the things that, you know, TMJ is kind of easy. It's a lot of behavioral modifications. But really, when you have someone who's young, who has a pretty like common problem, you also want to ask the patient, what do you think it is, right? What are you fearing? Because we have a lot of these kind of easy things that we can pick up that are very common. Even if it is like an ear infection or just he's grinding his teeth, he has TMJ, which is really common. Ask him what they think it is. If he's like, I think it's cancer, right? You can definitely reassure a patient. In this case, he said, you know, I've been going through a lot of stress. I've got finals, and a lot of it is actually related to stress and anxiety. So about 10 to 20% of primary care. Oh, sorry. Give me a second. Hey, I'm doing the thing. My husband's coming in, but he's bringing me coffee, so it's okay. All right, sorry. 10 to 20% of patients consult primary care for a mental health condition. And about 40% of primary care visits and patients who come to primary care have some kind of diagnosable mental health or behavioral health condition. So we do see it a lot, even in something simple like ear pain. All right, next patient. You have an 8-week-old well child visit. Anyone have younger siblings or any experience? All right, so what kind of questions do you ask? You have a kiddo coming in with his mom.
Did you hit it anywhere, like the affected area? Did you hit it anywhere?
New visit, totally new. This is like you're just coming in and you're like, okay, I just have this baby to make sure, you know, what kind of things mom just brings you in the room. She's like, you know, it's just a general checkup. What things are important at this, you know, like in general, you don't have to say specifically for an 8-week-old, but for, you know, a peds visit.
I guess I would ask like how the child has been and if she's been experiencing any issues, postnatal issues and stuff, since he's only 8 weeks old, or he or she is only 8 weeks old.
That's great. So mom's concerns, right? Maybe she doesn't have concerns, but it's her first baby. Birth history is important. Born full term, you know, via C-section. You kind of sometimes want to know why. Maybe it was just failure to progress in labor. Are they breastfeeding? You know, or are they doing formula? How is baby sleeping? And also, like, how long is baby sleeping and how is baby sleeping? Is it in the bed with you, right? You can talk about safety, things like that. Developmentally wise, you know, are you doing tummy time? Is he lifting his neck up? Is he kind of reacting to sound, following face? Socially, there's not too much, but social history wise too, it can kind of be like, who's in the house with you? Who lives with you? Are there any smokers, right? You're talking about safety as well. Is dad involved? Who's helping, you know, helping you out? And then vaccines, which is also really important, especially sometimes with different communities and anti-vaxxers. It is a difficult conversation to have, and if you have questions about it, I use a lot of words like, you know, protect, and make it kind of very normalized. All right, this is just kind of a cheat sheet that I have. I have a little booklet in my clinic that basically goes through the Academy of Pediatrics, general things to look for. You know, this is again the 2-month visit, and so are they lifting their head? It's really quick things, and usually parents will kind of you know, cross off or like fill out a questionnaire, right? And then I think what Michaela was saying is that you're also looking at mom, right? So I'm counseling her. I'm saying, okay, we're going to get our vaccines today. It sounds like, you know, baby's growing well. Look at this growth chart. It's beautiful. Keep breastfeeding. You should be having, you know, all these wet diapers and doing tummy time. And she is looking at you. And if you look at her, she's just tired. right? So again, I think thank you for kind of picking that up, because there are two patients in the room, especially in family medicine. We do a lot of maternal health and prenatal care as well. We deliver babies and then we see them in the clinic. And so postpartum, what are some, does anyone know what the kind of number one complication of postpartum, like, post-birth is?
Is it PPD, postpartum depression?
Yeah, I tell you that all the time in the hospital. So you're asking about mood, breastfeeding. So, knowing about we spend time with the lactation consultants and can at least counsel on that. Food is also really important, especially asking them if we need to fill out any forms for them to get WIC or kind of like federally provided, formula and things like that for babies' health, relationships, screening for intimate partner violence, and then also importantly, kind of in the 6 to 8 week follow-up for mom is family planning. Do they want us to put in an IUD? Do they want a Nexplanon? They have questions about birth control and family planning, and if they can take these hormonal pills if they're breastfeeding. Things like that are very common. So I think it's important, again, to know who the patient on your schedule is, but also be able to help the mom as well. Okay, visit number 3. So you're moving through clinic. You have a 58-year-old male now who's coming in. He was told to come in to follow up on his labs. Doesn't go to the doctor much. His BMI, are you guys familiar with BMI? Cool, yeah. Body mass index is 37, so he's on the heavier side. His blood pressure is 167 over 92 and pulse 70. What do you guys think about that?
I think it's a bit high.
Mm-hmm. Yeah, that blood pressure is it's definitely elevated. And his lab results that he was called to come in for is an A1C of 0.3, and also just kind of a dyslipidemia or elevated cholesterol. I didn't want to go into too much details, but does anyone know what the A1C test is and kind of what it shows us?
Does anyone want to go? I believe it's to test your blood sugar, and I believe people.
Yeah. So go ahead.
Oh, I was going to say, like, I thought if it was above 6, they are diabetic or pre-diabetic. I'm not too sure.
Close. It is a way to diagnose diabetes. You're correct. So the A1C is actually kind of the way that I explain it to patients is that you can take the test every 3 months and actually looks at your blood. It doesn't matter if you have like, a cake for breakfast, like people are like, oh, I ate, I wasn't fasting. It's actually an average of sort of the percent of your blood cells that have sugar attached to it, like glycolated on it. And so a red blood cell can live for about 3 months. So you can get it every 3 months to get the average. And it's A1C of 6.5 is considered diabetic, but over 5.8 or so, and kind of in his range at 6.3, he's pre-diabetic. So there's kind of some counseling on that and also still some medication options. What do you recommend just based on this? Like, what would be some recommendations in terms of overall health and treatment of this high blood pressure?
Would it be dietary changes?
See that now, right where you left off? Okay, lifestyle medicine. Love it. So part of family medicine, part of primary care is also prescribing, exercise and nutrition. And there is actually kind of a rhyme and reason to it. And to kind of, meeting patients where they are is really important. I think he would probably benefit from, blood pressure medication, things for his diabetes, but really ultimately, I always tell patients, when you look at the differences and kind of the decreases in blood pressure that you can attain through different types of medication, number one is still weight loss. It can decrease your blood pressure more than any pill that we have. And so that's so important, as well as eating healthy. And so there are so many resources, and no matter kind of what field you go into, lifestyle medicine has definitely been kind of at the forefront of just, partnering with patients to listen to their lifestyle, see what they're willing to change, and kind of going into like motivational interviewing and all of that as well. All right. And then what else? So it's primary, he doesn't go to the doctors much. What else do you think about in this guy who's 58, maybe not the healthiest? What other primary care things do we think about?
I feel like their occupation is important. Like, does their job require them like lift really heavy things, a lot of physical exertion?
Mm-hmm. Definitely. Yeah, knowing their social history, seeing what fits with them. So many times people say, well, I'm really active at work, but it's kind of getting that heart rate elevated at a certain, level and sustained activity for that cardiovascular health. Here we go. So there's also, cancer screening and vaccinations at this age. That's an opportunity to always talk about preventative health. And then one kind of quick relevant thing, especially now with the pandemic and COVID-19, is that we're seeing a significant decrease in diagnosing cancer. I work for Kaiser, and we do a really good job at population health. We have really like the main killer of the Kaiser population is actually cancer. Pretty much everywhere worldwide, it's cardiovascular disease, but we've really honed down on our like diabetes and high blood pressure control to the point where COVID cancer is really what is affecting patients in terms of mortality. And basically, because of this kind of shift in healthcare resources and also like providers and things like that, people are scared to come in. We are not detecting cancer. And so it's not only is the pandemic obviously affecting all of our lives, but it's also affecting the preventative health and what we're able to do. So that's sort of one of the impacts, again, resulting in a decrease of 65% of new cancer diagnoses. And it's not that cancer is going away, unfortunately, it's just that we're not picking it up. All right, so this is our fourth case. You have a 34-year-old female who presents with abdominal pain. There are a lot of questions you can ask, but do you guys remember kind of the, you don't have to remember the mnemonic, but sort of the main things in that mnemonic? What kind of questions are you asking?
Location.
Mm-hmm. Little quick questions.
When did it start?
Mm-hmm. Timing. And S setting, save.
I forget what letter it is, but like on a scale of 1 to 10.
Mm-hmm. Quality.
Is dull or sharp one of them?
Yeah, that's definitely quality as well. And sorry, quantity is kind of like on a scale from 1 to 10, you're giving it a number. What about, so you did little quick questions to save. You kind of said like timing, setting, when did it start? What about the M? Do you guys remember what M is? It's okay if you don't. I just, it's a new thing. Modifying factors. And then A is associated stuff, anything that's associated with the primary complaint, right? So location, it's kind of around the belly button. It's the sort of dull 6 out of 10 though pain, and kind of can radiate down to that right lower side. It started 2 days ago, but was really gradual, kind of in that belly button. And now again, it's 6 out of 10, which is why she's coming in. And she didn't do anything otherwise, like in the onset, no trauma, no other no GI bug or anything like that. Initially, Tylenol was kind of helping her, but then it just stopped working. The pain got too much. And then eating was making it worse. She felt like she had chills last night, but doesn't have a thermometer. She's getting some nausea and no vomiting though. Just again, eating makes it worse. She doesn't want to eat. What kind of things are you guys thinking about? Or any questions, sorry, more questions that you want to ask?
I feel like I'd ask if there's any recent changes to their diet, just because it seems like an issue with their GI system.
Yeah. Oh, say she's got some looser stools, but otherwise no changes. No one else had like any kind of symptoms in the household, and they've been all like eating the same food and stuff. Good question.
I think I would ask like her sleeping schedule about her sleeping schedule and like her menstruation because I know that like with menstruation, GI problems are often like really common.
Yeah, that's good. She's actually said surprisingly, "Oh, I'm a week late on my period. Normally I'm pretty regular." Great. That's a great start. Okay. And so what are you thinking about when you ask those questions? Like what's on your differential in terms of the diagnosis? What do those, questions lead you to think more, more for or against what the diagnosis is?
I'm thinking about if it could be caused more by her diet or more by hormones or internal processes that are not affected by external factors.
hmm Yeah, kind of behavioral, lifestyle, that kind of stuff. This is like you're looking at a person, right? So like, the pink is kind of that right upper quadrant area. But there's a bunch of different things you can think about. This must be like a European thing, but like gynecologic on the bottom, like where your ovaries are, you can have your ovary be like twisted if you're on that, in terms of cycle. Or it could be a pregnancy that's not where it's supposed to be, right? This is a 34-year-old female. And when you're asking about like sexual history, is she used condoms, is she on birth control, you kind of get into that as well if you have those concerns. That right lower quadrant is always concerning for appendicitis. That's kind of the number one thing as well, which can cause that. And a lot of times it does sort of start around the belly button. Kind of higher up, you worry maybe about stress, how she's eating, that behavior. Does she have ulcers? Kind of like a dyspepsia. Is she eating a bunch of spicy food, right? Or drinking a lot? Is she a smoker? And then, you also kind of just kind of going off the pink area, right? That right upper quadrant, that's where your gallbladder is. Pylo is kind of like where your, kidneys, you can kind of check the back. Does she have any urinary symptoms? Did she have a UTI for a week and not treat it? And now it's kind of coming up and really hurting her. Again, where your liver is. Sometimes pneumonia, that would be, that would come with a lot more respiratory symptoms. The green square, again, you're looking at the kidneys, and then maybe even kind of that upper area where the stomach might be. And then kind of going to that lower quadrant area, again, appendicitis, right lower quadrant. That's kind of one of the things you definitely look for. Hernia, IBD is kind of inflammatory bowel disease. And so people can have a lot of like bloody diarrhea, things like that. That's like Crohn's, ulcerative colitis, UTI, like we talked about. And then, male female issues being kind of like where your ovaries are or kind of a testicular problem, kind of similar on the other side as well. So lots of things to think about with abdominal pain. So going to the exam, her temperature is 100.6, blood pressure is 90/60, and pulse is 110. What do you guys think about that?
It's a really high pulse.
Yeah, sometimes it can be elevated from pain, but you always want to worry about other things too. Is she bleeding from somewhere, right? Does she have a ruptured pregnancy in one of her tubes that shouldn't be there? In general, like I said, first look at a patient, she's ill appearing, she's in mild distress, she doesn't look well. And then you listen to her heart, it's going fast, like you said. She's breathing okay. And then on her abdominal exam, it's still soft. It's not like super hard or distended. You can still hear active bowel sounds. There is tenderness to palpation, TTP, kind of in that periumbilical area, and also in that right lower quadrant. Other things that you may do are kind of like tap on the back, like where the kidneys are, to see if there's any tenderness there. When the kidney gets swollen and kind of inflamed, there are nerves that can cause kidney pain. Also why you can have like kidney stone pain and that kind of stuff too. One thing too is if you see her walking and she can't even, you don't think she could even jump, that's what we call an acute abdomen, where, you know, you've got this kind of guarding. And sometimes now that we're in the age of video visits, people with abdominal pain that I'm still kind of worried about, but like no fever per se, I'll have them do some jumping jacks for me just on the video to see if they can do it. Because people will be like, oh, as I was driving here, every bump in the road was, you know, like really hurting me. And that's actually more concerning because there's possibly a ruptured appendix that's kind of inflamed, and the whole stomach area is really sensitive. So what would you do next? She's in your clinic.
Would imaging be necessary? Is that something we can pull up really quickly?
Yeah, I would want imaging. I would want it quickly. So I'd send her the ED. She's also has a fever, right? She has a fever. Her heart rate's going a little fast. Her blood pressure was kind of on the lower side too. So I'd want to know, is she anemic? Is she bleeding? What's her imaging like? You know, you get blood tests pretty like a lot quicker. So I definitely wouldn't send her home. If it was a telephone or a video visit, I would probably tell her to come in as well, especially with that right lower quadrant area pain being concerning for the appendix. All right, that's only 4 patients so far, right? This is like a half of our morning. This is our last patient, just last patient example. You have a 14-year-old female. She's here for a sports physical. She's a triathlete, high school freshman. She is on the varsity track and field though. She is awesome. What kind of things do you want to ask for a sports physical if you guys have done that? And also for a 14-year-old female?
Are they on birth control?
She is not on birth control. She has not had sex yet. And I do this, you know, one quick kind of one-liner thing I do is I just say, hey, you know, you're 14, you're a teenager, you're going to go to college sooner than you know it. When you're there, you're going to be alone, you're going to be independent. And so I like to talk to, you know, all my teenage athletes or all my teenage patients by themselves, right? And then I kick the parent out and I talk to them. So that's how I ask my, kind of those questions, right? Birth control, sex, relationships. Anything else?
What sport are you doing?
Mm-hmm. Yeah, so she's like, I'm track and field, and I also do triathletes competitively. Like I rank every time, you know, I'm swimming in the mornings and I'm biking in the afternoons, and I run like, you know, 5 miles a day. It's a lot.
I feel like to also ask if she'd made any changes to, like, her level of activeness or if she, like,
Mhm.
has been working extra hard lately to prepare for, like, the competition or something.
Yeah, there's a lot of pressure on her since she has been kind of ranking in these different triathlons. She's kind of moving up to like traveling nationally for them. Like obviously this is pre-COVID, let's say. You know, trying to place and kind of get recognized there.
I remember like whenever I go to Kaiser for a physical, like they ask when like obviously when the mom's not in the room, are you doing any like drugs or alcohol?
Mm-hmm.
I feel like that's really important, especially when you're in high school.
Mm-hmm. Definitely. I always like to start with like, you know, what are your friends doing? Oh, have you tried what your friends are doing? You know, especially at this age, it's a lot of your friends are your world, right? And so those are your relationships, and kind of go, you know, appreciating that in a young female or any young adult. All right. Yeah, so another kind of mnemonic is the heads. It's HEA. I don't know. Anyways, I go by it similarly, but this is just a photo I saw kind of online, which goes through pretty much everything that I do. I ask about home. Do you feel safe at home? That's a big one. Education. What do you want to do? What are your plans after high school? Do you know what you want to do yet? Eating, and especially in females, do you like body image? Also males, actually, I would say equally. Do you have any body image issues? You know, how do you think your diet is? A lot of diets are mainly chips and like hot Cheetos and stuff like that, but also knowing kind of if they feel guilty about eating. Activities, what are they involved in? Like you guys said, drugs, alcohol, vaping, obviously, sex. Who are you interested in? You know, like, are you interested in boys, girls, or you know, both? I think is definitely an important question that I always ask. Suicidality is something, again, like the 21-year-old we had first, very important to assess. And yeah, very important to assess and kind of prevent suicide and the loss that can leave families. And then safety wise, kind of with social media too, like, what's your screen time is like a good one that I always like to ask. Like, you go on your settings and their screen time is like 4 to 6 hours, right? And then you can see what they're using it on. It's a lot of TikTok, a lot of Instagram, all that stuff. Great. So you do the exam, and then you eyeball first. She's pretty slim. She looks athletic, but she's otherwise healthy. Heart and lungs, cardiovascular and lungs are normal. Abdomen's normal. In terms of her kind of MSK exam, this is definitely a shortened version, but you're looking at how she walks, how she moves her joints, what her strength is, upper, lower extremity. And then you notice that she does also have this tenderness over her shins. And I said, oh, is that usually tender? And she says, yeah, actually, when I run, I get a lot of pain in that area. All right. And so let's pretend we get an x-ray and we just have it with us. You take a look. This is her leg, kind of her shin area, and you see this little line. This is called the dreaded black line. It's actually what physicians say, like, you're looking for that dreaded black line. What do you think that represents?
Stress fracture.
It's like a hairline fracture, I think.
Yeah, both similar. So she has a stress fracture. And what do you think about that? What do you think about a stress fracture in this pretty active, slim female? And is there anything else you might want to ask? And again, this is it's a leading question. You may not know, but other things that you might think about. First of all, are you worried about it? Yeah, okay. So we're worried about it. Young people generally don't have these kind of bone issues for the most part. And I think we might have mentioned it with like in a female 14-year-old, what is another question that you definitely want to ask as it relates to puberty?
I feel like we should ask about just like her nutrient intake. Like, is she getting enough calcium to support her bones?
Yeah, is she purposeful about her recovery food, right? She could be eating a normal diet like all of us, but if she is expending so much, like all those calories, then she's not keeping up with what her body needs. And another sign of that could be her menstruation, right? So you can ask, do you have periods? And she said, I started at the age of like 12 and a half, 13, had them for a few months, and I haven't had it for 6 months, right? And sometimes that can be, sometimes at this age, when you're first starting to have periods, having irregular cycles can be normal. But when she's kind of had them maybe regularly and then stopped, we wonder about that. I usually tell my females, 3 months, no periods, let me know, just so we could talk about it. So this is something that I'm really interested in. I've done research in it. It's called female athlete triad, which is kind of shifted to be called RED-S, which is relative energy deficiency in sport. And so traditionally triad was a triad of basically kind of nutritional issues. So it started as kind of like disordered eating, but can really be just not eating enough to have your input doesn't match your output in terms of calories and energy. Irregular periods is the kind of second part of it. And then the third component is low bone density, osteoporosis, stress fractures. A lot of times these athletes will come in with stress fractures because we don't really, unless they say like, I am struggling with eating, we don't know until we ask. That has been expanded, and I think rightfully so, to include males. Males have similar issues and can have a lot of those hormonal imbalances due to decreased, relative energy deficiency. So they're also not eating enough. We see it commonly in kind of weight-related sports, in wrestling or aesthetic in dance. And so it's sort of, I love it because it includes, mental health in athletes, includes nutrition, lifestyle, and it also is related to, sports performance and how, like, the physical aspect and muscles and bone health. So all of that together. Awesome. So that was let's say that was half my morning. That's family medicine, right? It's pediatric adolescent care, it's women's health, it's postpartum, it's chronic conditions and starting them, diabetes, high blood pressure. We also get a good amount of geriatric care. It's screening, it's prevention, it's urgent care, knowing who's sick and who we need to send over, what's alarming and what's worrisome. It's a lot of mental and behavioral health. It's sports medicine. And then I also really love doing procedures, toenails, freezing things off, doing biopsies. I also like doing like Nexplanon, which is an arm implant for birth control, IUDs, another kind of thing. I do a bunch of women's health, cervical cancer screening, pap smears, and I love it. And so it's just kind of the mental gymnastics of family medicine, going from room to room and sort of shifting your focus and shifting what you need to know about patients and kind of know just based on their life and also their age and their health conditions. So this was again my day, or kind of my morning, your virtual shadowing experience. Hopefully the little quick questions to save my bottom, and then asking the patient, what do you think it is, to really address it. They'll feel like you listen to them, because if their one concern is that they think they have cancer, right? And you just say, I don't think you do not have this, right? That can really, in the short amount of time that we generally have in primary care, it's really important. And again, mental health, in terms of well child, again, just kind of preventative stuff, anticipatory guidance, as well as looking at mom and the whole family, because that does affect baby's health as well, right? It's that postpartum care. In terms of kind of having patients with chronic conditions, you're kind of partnering with them. You have the lifestyle medicine and then preventative health, and screenings and all of that, vaccines. For abdominal pain, kind of knowing a broad differential, and having the clinical decision making to determine whether or not you can do this in clinic or they just need a higher level of care. And then with that sports physical we had, again, it's a lot of adolescent medicine, how to talk to them, what specifically is kind of part of their general routine checkup, as well as mental and physical fitness and, red S, and kind of combining all of that together. So hopefully those are the sort of learning points I wanted you guys to get from the virtual shadowing. And then the crazy thing that I wanted to move on to is that, the medicine becomes easy. And I think it's hard to see that, especially now, especially early on. But it's really the relationships, how you're talking to patients, how you kind of get into their why, and connect with them. That is the hard part. When they disagree with you or you disagree with them, when they don't want to listen, or you have to meet patients where they're at. The medicine becomes easy. We know what medicines work. We know, how to best treat certain conditions, but it's really the relationships. And I like to think family medicine is a specialty of relationships, because we really get to connect with our patients on that level. And that kind of brings me again to the art of medicine. Like, why are you guys doing your extracurriculars? What are you doing out in the community? Everyone, I've reviewed med student applications and residency. Currently, I'm reviewing residency applications. And for the most part, the medicine, the knowledge is there. It's pretty solid in general for kind of everyone we're looking at. It's that extra thing that we think will make this person a really good physician and really know kind of the art of medicine and understand that it's more than just the knowledge and the books, and the medications and stuff. So that's pretty much it. Hopefully you guys enjoyed my virtual clinic shadowing experience, kind of learned a little bit more about what family medicine does. And then again, that art of medicine I think is important I just wanted to close with that. And if you guys leave away with anything, just know that it's worth it in the end. Big picture, you're gonna learn that, you're going to get the knowledge, you're going to learn the things, you're going to memorize the meds and all of that stuff. It's really what I find meaning in my work is that art of medicine and connecting with my patients. Well, that's it. You guys can take a photo or send out my email. I'm happy to help in any way I can. All right.
Awesome. Thank you so much for that. That was such a great presentation. It was very insightful. Like, not even just with medicine as a profession, but as art, like you said also. So we're gonna move on to our Q&A. We have
Mm,
some presentation related questions and also some questions from the community just about like your journey and things like that.
mhm.
So whoever would like to start, go for it.
Hi, Dr. T. Thank you so much for your presentation. I wanted to ask, like, for one of your cases, you brought up lifestyle changes for patients who have like high BP, high cholesterol, and like some people can like hesitate to make these changes. And I was wondering if how you would go about like finding a compromise
Mhm.
for these changes that will have like a net benefit for them. Like I
Mhm.
wanted to know if do you use like motivational interviewing or just what is your typical like go-to method for it?
Yeah, there's a lot of motivational interview. That's a good question. It's hard to change behavior, and if you think that you're going to change a patient's behavior, you're going to go crazy. You do the best you can, especially in primary care. Starting with small steps and having really kind of direct goal, like small, like doable goals. Some people will just be like, I always like to start with like soda, for example. Like soda's a big one, juice, right? And then I do kind of like the small frequent meals. And then if people are really into it, then I'll talk about like plant-based diet and things like that. But I never honestly really get there. It's a lot of portion control is kind of the low-hanging fruit that I go for, and then cutting out soda and sweet things. And then some people will be like, oh, I drink a soda every day, I'm just going to cut it out. And I'm like, you know what, I couldn't even do that, and I kind of like relate to them on that level to say that like maybe you could just be on birthdays or like something else. Like it's people really want to do something. And when you're doing motivational interviewing, some of my favorite questions to ask are like, in your ideal world, what would it look like? I do this for people who have substance use disorders as well, who are addicted to meth or any other kind of substance. I said, like, in your ideal world, like, what would it look like? And they'd be like, I'd be with my family again. I'd be off this. And like, how do we get there? Right. Because you see kind of that dissonance of like what they're doing and where they're at. And so I do similar thing. That's just a general motivational interviewing. And then I kind of ask like, what is your like motivation to do it? And how confident are you? Because those are two different questions. People can have a lot of motivation, but they don't have the confidence that they can do it. So kind of breaking people's motivations and desires and down like that is kind of helpful. And then doing really these like small goals, checking in with them often. I'm happy that at Kaiser I can do a lot of telemedicine, so I remind myself to check in.
My question is, so you mentioned you have to have conversations with vaccine deniers or other people who it's kind of hard to relate in terms of trusting conventional medicine. How do you have those difficult conversations?
Yeah. Another thing that if you think that you can change people's minds, you're going to go crazy. But I think one of the best pieces of advice that I've gotten from one of my mentors and attendings is that you want to make sure that the patient knows and the parents know that you're on the same team. Like that they're not like anti-vax because they want their kids to like die, right? They think that what they are doing and their decisions are the best for their kids. And I reiterate that. I'm like, it's my job. I know you've heard it. Like, thank you for having this conversation with me. And a lot of times asking permission is also important, like with obesity, right? Or weight, like, hey, can we talk about this? So opening that conversation, again, it's all sort of like people skills and connecting. But yeah, can we have this conversation? Thank you for having it with me. I know we're on the same team. We want the best for, Jake or whoever the child, we want the best for your child. And then kind of going from there. And some people have said like, maybe I just want to do an alternative. And I'm like, I take that as a win. Like they're just going to do an alternative schedule. They want to wait until like the developmental years are over or whatever. It's better than not doing it, but we have been told, and kind of the evidence behind vaccine conversation is that trying to change each other's minds and things like that is not usually very effective. So it's a lot of partnering again and empathy.
Another question, earlier in one of the patient cases, you mentioned postpartum depression. And so how do you go about addressing mental health in a clinical or hospital setting?
Yeah. Um, we we really have to choose to do it because time is very limited. It's something that's really important to me, and so I tend to do it more, and we advocate for that, and we normalize it, right? Like every routine physical I have, I say, oh, this is also something I ask of every patient all the time. In the past 2 weeks, have you felt sad or depressed, lost interest in things, had worrying that you can't control? That's basically, I mean, that's it. It takes 15, 20 seconds for me to just put it out there, and then people can do with it what they want, and I'm okay with that. Um, in the hospital setting, actually, you do have more time, which is interesting because they're just kind of sitting there. So I do a lot of my postpartum counseling on the labor and delivery floor before they go home with their new baby. I talk about it. They get a bunch of resources just also through our Kaiser system. And yeah, and kind of normalizing that conversation, always being available when people don't feel like talking about it, just being open and saying like, I am always available if you need that, or if you need that extra support. And then when someone kind of has a predisposition to depression or anxiety, talking about suicidality is, it never plants a seed or causes someone to do it or think about it. I always ask about it.
I had a question about like suggestive forms of treatment. So what would you do if the patient does not want your suggestive form of treatment, and how would you go about the situation?
Yeah. Always start with why, right? Like asking them what their worry is, because sometimes you can easily address their worry, right? Like, I don't want to take this cholesterol pill because I heard that it has so many side effects and it'll cause, muscle aches, right? And you can address that directly. I think that's the easiest thing to do is like, oh, okay, like, why don't you want to do, or can I ask, like, what are you worried about, or what are your concerns? And then you talk, and then if you can kind of go through that, and then the next question is, what do you want to do about it? Like, what's your plan, right? To, you have all these issues. And then if they're like, I just want to do diet and exercise, that's when I get on them and I'm like, all right, so in 2 weeks, like, what's your weight? I'm like specific about it, and I have close follow-up, which I'm able to do, fortunately, in my clinic.
We have a community question. So,
Mhm.
how did your experiences studying abroad help you in your journey through med school?
Yeah, I don't know if that was kind of, so I studied abroad in undergrad. I don't know if that was confusing. I traveled a lot in med school. I would say again, it's all about connecting with people. When I was studying abroad, we would travel to hostels, we would do last minute things, we'd be spontaneous, you would meet random people all the time. And it's really kind of listening to different stories, getting to know people, and then also making an effort to learn the language of wherever you're at, learn the culture. So a lot of that kind of cultural, humility and understand, connecting with people. It was really fun. Medicine is a really long journey, and I'm glad that I had a time in my life that I was able to just have like almost very little to no responsibilities, and have fun and make really good relationships.
Um, I have another question. So, can you share your experience as a minority in medicine and how that shaped your approach to medicine and healthcare?
Yeah, that's a great question, and definitely something that's important. Again, I'm representing my doctoral shirt. Um, so there's a couple different things, when you're a learner, when you're in training, and when you're young and look young, and when you're a minority, I think, are three sort of big things that are always there. We learn a lot about psychological space, and kind of the space that you do take up. So I do appreciate, and I know that when I am at like the VA, right, dealing with older, like, white males for the most part, I wear my white coat, and I know when to also dress myself down when I'm on the field covering football games, or when I have a pediatric visit. For the most part, if it's a kid or like a teenager, I'll dress myself down. I won't wear my white coat. But there is a lot of extra kind of effort and cognizance that I do take, knowing that I look how I look, and that in the field that I'm in, um, you know, there's been tips. There's a really great community, I think, of like women in medicine, minorities in medicine. Again, this is another reason I'm very thankful to be here and kind of pass that forward and be available to you guys. But yeah, I mean, I've heard some female physicians also say they always introduce themselves twice and say they say doctor, right? Like I'm Dr. T. I'm so glad to be your doctor today, or like something like that to kind of really, it's tricks that we adapt to and we have to learn to just because of our society, right? But I think it's important that, you know, we have it's important for young people to see that their doctors look like them. I would say some of our medical assistants, most of them are from Mexico or of Mexican, you know, from like have Mexican families. And one of my co-residents, Lucy Martinez, is a big, you know, her parents are from Mexico. She's from Central Valley. She takes care of their kids, and she loves that relationship part of it, because it's important. I've had kind of younger Asian families come up to me and ask if I could be their kids' doctors, I think, for that fact as well.
Go ahead, Jed.
Yes. Were there any non-academic things that you did to prepare yourself for like family and sports medicine?
Oh yeah. A bunch. I think coaching volleyball. I worked as a physical therapy aide as well, which is an entry level position. If you're able to find that, and I did a private physical therapy office. I did that. I mean, I worked at a beer garden. You deal with people. I would kick drunk people out all the time, and like talk with them. Let's see. Yeah, the coaching volleyball, which is how I met my husband. And I think just like on-field coverage, like I would volunteer at like marathons, and I did a pro sand volleyball tournament, just kind of being exposed to it in residency and in med school. I would do coverage with some of my mentors as well. So I would do sideline coverage, seeing kind of like high school football games, things like that.
Thank you.
Yeah, I love being out on the field. It's the best. I love sports medicine, obviously. So.
Can you talk more about Kaiser and its patients relatively to, sorry. Can you talk about
Yeah.
Kaiser and its patients' relatively low incidence of death by cardiovascular disease?
Yeah, so Kaiser as a whole has a has a program that's actually headed by clinical pharmacists. So I also, if you guys are pre-pharm, you guys save my butt all the time. Like when I'm in the hospital and I'm putting in orders, they'll like call me from regional, be like, do you want to do this, or can we like put this down? It's like a frail old lady and her kidney function's not great. Things like that. You guys like are MVPs for sure. But yeah, sorry. It's head by our clinical pharmacists at Kaiser, and really they're the like diabetes and hypertension specialists, right? So we have a lot of metrics as a Kaiser physician to kind of meet, you know, A1C goal less than 7 and at least like 60 or 70% of our population, for example. And we really try to meet those metrics. And by doing that, we are, you know, decreasing that incidence of heart attack, of stroke, to the point enough where they've looked at, you know, social determinants of health and how, for the most part, you know, people of color die more often than white people from the same issues. And we've actually been able to kind of equalize that as well a little bit more. And then also just decrease the mortality from cardiovascular disease in general, to the point where, again, you know, now it's kind of like cancer screening and picking that sort of stuff up. Which is really cool. I was a public health major, so I love being part of this system. A lot of other places have different metrics. You have to see as many people as you can, as much as you can. You know, you have to do as many procedures because we can bill for it. Kaiser, for the most part, just wants it, like, it's evidence-based. We keep people healthy. We do our screenings. We keep our numbers and our, you know, blood pressure and our diabetes levels under control to prevent, you know, to prevent disease.
Can you describe the process of choosing your residency focus?
Yeah, so from medical school to residency, like to choosing family medicine, right? I chose family medicine for a lot of reasons. I think my background in terms of what I enjoy doing. I thought I was going to work for the WHO and do epidemiology and just kind of do public health and travel and maybe work for the CDC or something. And then medicine was always on my mind. And when I realized that I didn't have to choose medicine or public health, that I could do both, the only fit for me and the best fit for me was family medicine. I think as family medicine physicians, we're able to be more than physicians. That's what I didn't want to be just a doctor. I wanted to be a teacher. I wanted to be in the community. I wanted to be out there and have this knowledge set that could apply to everyone wherever I went in any community. And that, I think, is what family medicine is, because we understand that food is medicine, exercise is medicine, security, safety is medicine. And so that's why I chose family medicine in particular. And then I knew within family medicine, I could also do sports medicine. So I hope to do sports and family as well. That's kind of my ideal practice in the next 3 to 5 years.
Hi, Dr. T. So the community that we're catering this virtual shadowing for our undergrad community and the Philam community. And, right now it can be quite hard to find experiences and pre-med experiences. And I wanted to ask, what were those pre-med experiences for you, and what did you find most interesting for you prior to going to medical school, and if you have any tips in getting involved with that?
Yeah, I did some shadowing and it was cool. It was kind of similar to hopefully what I gave you guys today. I saw that a guy who was family med and sports medicine, who was also a DO actually, not an MD, but again, I have really close friends who are DOs. I wish I knew what DOs know, because their MSK knowledge is definitely above the MD, kind of the way that our training is. But yeah, so I did some shadowing and I kind of just saw, I had good patient examples of kind of why I liked medicine. And that was helpful in that regard. I never volunteered at a hospital. I never was a scribe. Again, I worked as a physical therapy aide, just because, again, I like kind of the sports aspect of it, and it was just what was available. I didn't have much specific pre-med. It wasn't like a pre-med thing. I mean, I did some free clinic stuff, I guess, at a Filipino clinic in San Francisco, and was kind of like a health coach there. But I just sort of fell into that based on kind of my network, my people, my community. It is definitely hard. If I were in your guys' position, I honestly wouldn't really know too much of what to do, other than to continue to ask, continue to be curious, and to find mentors. That's really important, is to find mentors. And you'll be surprised that when you reach out to people, they may be busy and all of that, but we go into this profession because we want to help people, and we want to continue to grow, especially minority female, female minority physicians, because it's important.
When you were talking about being a health coach, was this for the Mabuhay Health Center?
Yeah.
Yeah.
Nice. Yeah, that was fun. I did a lot of, I was there when they first opened, so I did a lot of publicity and kind of connected the community. I think Gavin Newsom came. We did a ribbon cutting ceremony, and then I spent the next 6-7 months or so doing kind of the health coach training. I think it was at UCSF or something like that. And then and then I kind of got busy and got more into public health teaching and stuff like that. So I ended up stopping that, but it was a good experience.
Yeah, so we definitely network with them.
Nice.
A lot of our FAC alumni would go and volunteer at the health center, and so it's a great resource, especially for the Soma community.
Yeah, and help in any way you can. Just ask how can I help is really one of the best questions you can ask. If it's handing out flyers, but you feel like you are part of a community or part of something, and you're helping that community get out there, then do it. It may not be medical related, but you'll make those connections, and you'll meet those mentors that can help you.
All right, and we do have a tradition here at FAC, just a question we ask all of our guests that we always have, and it's just, what would be your biggest piece of advice that you'd give to us?
I would say my advice is do what you love to do and trust that everything else will follow. Because it, I don't consider myself a traditional applicant in terms of like doing the research and like doing. I eventually got into it, but it wasn't kind of a checklist for me. It was just, what did I like to do? I like to work with kids, so I mentored kids in Oakland. Like I love to travel, and that's kind of what I got into, and my minor and everything. And then that'll kind of like following your interests and following your interests will show in your application and your extracurriculars, and you can really passionately talk about it. So when you are interviewing and you're writing your personal statement, and other small things, journal if you can. I'm a big journaler, just kind of remembering your experiences, and specific ones as well, because it can be very situational in terms of interview questions and stuff like that. But yeah, like just continue, like find what you love and do it. If it's dance, if it's music, those are the interesting things that I like to ask about when I'm interviewing people, because that's what I think. I love seeing people, brighten up and start talking passionately about something.
Thank you so much for that. That was so awesome.
Yeah.
But yeah, thank you so much again for joining us today and taking the time. I know you're super busy and you're applying to residencies right now. So I wish you the best of luck with that.
Yeah.
Also for the people watching later, just a reminder that there is a quiz down below so you can get your certificate and your accredited shadowing hours. And yeah, any other
Cool.
questions before we end it, my fellow board members? Last things to say.
Thank you again so much for your time, Dr. T. It was thank you for your insight and all that. It was definitely helpful and we appreciate it.
Yeah, thanks for having me. We as a residency do actual clinical cases, like in depth as well. We have all of the PowerPoints and stuff for that. I don't know if that's something you'll need. I can easily ask one of my interns or so, another resident. Like I can pair up with them. I mean, they're not Filipino, but we have a lot of kind of like young minority resident physicians if you want to do any more stuff. And they're more medical. I kind of went with an overview, sort of, that was my approach, but we can definitely do more medical stuff that we do with a community college that's affiliated with Stanford, in terms of like their pre-med club and stuff. So we do that as well. So let me know. And thank you for being patient with some of my connection issues. And you guys had great questions. So thanks for letting me share my story and part of kind of my daily life with you guys.